In terms of regional anesthesia, we specifically talk about epidural anesthesia, not intrathecal per se, or as most people would know, intrathecal is a spinal anesthetic. In adults, if you look at this slide here, there are several regions where we can provide epidural analgesia or anesthesia. They include the thoracic, lumbar, or caudal regions of the spine or vertebral column. As I said, an epidural catheter can be placed at any of these areas to provide specific analgesia, anesthesia for surgeries that involve the dermatomes of these regions. In terms of the anatomy, as you look at the slide here, the epidural space is the space that's outside the dural sac. The spinal cord is incorporated or sits within the spinal sac in a fluid-filled media called the spinal fluid or cerebrospinal fluid, and the epidural space is outside of the dural sac. When we do an epidural anesthetic, we're actually injecting local anesthetic into the epidural space, and it diffuses across the membranes to anesthetize the nerves of the specific dermatomes. In this image here, you can see that for the most part for neonates, we do what's called a caudal epidural anesthetic. In terms of neonates, the epidural space is relatively larger as compared to adults, and it's very easy for us to place the tip of the epidural catheter in almost any area of the vertebral column, which involves the specific nerves in the neonate. We can place in the caudal area, we can place in the lumbar area, we can place in the thoracic area by just feeding a certain amount of catheter into that region of the epidural space and administering the anesthetic into that region. We also utilize fluoroscopic technique to determine where the tip of the catheter is so we can precisely deliver the local anesthetic needed for coverage of the surgical site. In terms of the medications that we administer through the epidural, they include a local anesthetic and usually in combination with the opioid. Local anesthetics that we use include Bupivacaine and Ropivacaine. The narcotics that we will include or combine with the local anesthetic include fentanyl, morphine, and hydromorphine, or also known as Dilaudid. The reason we combine the two agents is such that we can minimize the toxicity associated with either or agent. In terms of local anesthetics, specifically bupivacaine, there can be significant problems with cardiovascular toxicity and or neurologic toxicity associated with it. With the narcotics, when you administer them into the epidural space, the common side effects associated with narcotics, which include apnea, pruritus, urinary retention, nausea, and vomiting, can be accentuated when you give it into a central location. Here at CHOP, we have done a study looking at the use of bupivacaine with and without fentanyl for neonates who have undergone resection of a congenital cystic adenomatoid malformation. And we were able to find that, again, potency or analgesia is much better if we combine the local anesthetic with the narcotic. Again, we were able to decrease the amount of local anesthetic that was needed to be administered to provide an adequate level of analgesia. There's been very little research in looking at bupivacaine dosing in the epidural in neonates. Really only one study, and that was done by Larson. And they demonstrated that at about 48 hours of a continuous infusion of local anesthetic into the epidural space, that there can be some rises in serum levels of agent. For that reason, we, for the most part, will only limit regional anesthesia or epidural infusions in neonates for pain control postoperatively up until 48 hours. We've also looked at alternatives to use of bupivacaine for a local anesthetic for the neonate in the epidural infusion for local anesthesia. These agents include ropivacaine, chlorprocaine, and lidocaine. All these have less toxicity associated with them as compared to bupivacaine, which can have problems with neuro and cardiovascular or cardiotoxicity. In terms of the neonate, again, I've mentioned this before, there can be significant problems with intraoperative fluid management. When we take care of babies in the OR, sometimes our neonatology colleagues are question why specifically the babies receive so much fluid. They feel that sometimes it's an inordinate amount of fluid that's been administered to the babies. And we've explained to our colleagues that we have to deal with three parameters in terms of fluid management in the OR. These include the maintenance fluid rate, the deficit replacement, which occurs in the OR and not postoperatively, and then there are ongoing losses, which include blood loss and third space losses. The deficit losses are not a problem because most neonates come to the OR with an IV in place, and they have maintenance fluids going. So when we're calculating what needs to be administered in the OR in terms of fluids to the baby, we're going to specifically look at what's required for maintenance fluid rates and the ongoing losses. And maintenance fluid rates, as I mentioned before, are pretty much set in the NICU, and they're going to come to the OR with their maintenance fluid running. We're going to focus our attention on ongoing losses, which include blood loss and third space losses. When I say third space losses, that's fluid that's extravasating in the tissue or is evaporating. A big component in terms of the ongoing losses, again, when we talk about blood loss, we're going to look at, as we described in anesthesia, allowable blood loss. You can lose anywhere from 20 to 30% of your blood volume safely as long as it's replaced appropriately in the OR. When you're replacing blood loss, the allowable blood loss, we're going to give 3 cc's of crystalloid for every cc of blood loss. Once we've calculated allowable blood loss and that allowable blood loss has been exceeded in the OR, then we're going to replace blood cc for cc with packed red blood cells. Third space fluid losses are determined by the surgical procedure that the surgeon is performing. For thoracic procedures, when the chest is open, there can be evaporative or third space losses, which can be up to 4 to 5 cc's per kilo per hour. In intra-abdominal procedures, where there's a lot of intestinal contents exposed to the environment, you can have, on the average, 10 to 15 cc's per kilo per hour of fluid lost into the environment. If the bowel is inflamed in situations like necrotizing enterocolitis, there can be up to 30 cc's per kilo per hour. These numbers have to be incorporated into the fluid administration because if they're not, the patient can become hypovolemic very quickly. There have been significant advancements in neonatal anesthesia in a very short period of time, relatively 30 years in terms of anesthesia. There was a point where the only anesthetic that we really used was a muscle relaxer and paralytic agent to keep the baby from moving. They would sense what was occurring to them in terms of pain and the stress of surgery. A lot of recent literature has shown that babies do feel pain and they do have physiologic responses to pain. The myth in the past was that babies would not remember because they could not tell you that they had the pain of surgery. But in terms of neurologic insult and imprinting of that insult or stimulus on the baby can occur for periods of time well after neonatal period. We've had babies who've had noxious stimuli or surgery in the operating room, and then when they come back as older children have almost a recollection in terms of their physiologic responses to surgery. So it's very important that we do anesthetize, provide an adequate anesthetic for these patients because there can be detrimental effects to their well-being.